It's the top of the hour, so I'd like to welcome our participants to the Antimicrobial Stewardship Project webinar series. The series was created by the Center for Infectious Disease Research and Policy at the University of Minnesota. I'm Dr. Marty Peterson, and I'm your host and the outreach coordinator for the project. We are pleased to have with us today 3 expert clinicians. And as you can see on the title slide, they are all colleagues at Rochester General Hospital in Rochester, New York. Dr. Mary Staicu, Dr. Maryrose, Laguio-Vila, and Dr. Alison Ramsey. And they will be presenting their webinar titled The Role of the ID Pharmacist, Physician, and Allergist in Penicillin Allergy and Skin Testing today. Before Dr. Staicu begins the webinar, I just wanted to welcome our participants and give you some information. To communicate and engage with our speakers today, we encourage you to submit comments through the chat box. So there's a bar at the bottom of your screen. You click on that, your chat box will appear, and you'll be able to send them questions and comments, and we will have time at the end of the presentation for that engagement and responding to your questions. The webinar is also being recorded, and handouts for this webinar and the recording will be made available after ID week, October 6th. So check back for that. So with that, I'd just like to provide a brief summary of our speakers' backgrounds before Dr. Staicu kicks it off. Mary Staicu, PharmD, is an infectious diseases clinical pharmacy specialist practicing at Rochester General Hospital. In her current position, she is a founding and active member of the Antimicrobial Stewardship Team and serves on various hospital and system-wide committees striving to promote the appropriate use of antimicrobial agents through clinical stewardship interventions, program and guideline development, and her own active research. Her specific area of interest is the clinical and economic implications of the penicillin allergy label. Our second speaker today will be Maryrose Laguio-Vila, MD. She's an infectious disease physician also at Rochester General Hospital. She is a founding member and director of the Antimicrobial Stewardship Program of Rochester General Hospital and a physician leader of the Rochester Regional Health System Stewardship Collaborative. She is also a core faculty member of the Rochester General Hospital Internal Medicine Residency Program, serving as a mentor and preceptor in the fields of infectious diseases and antibiotic stewardship. Her interests include social behavioral influences of antibiotic prescribing, meaningful measures of antibiotic use, syndromic stewardship, and the integration of antimicrobial stewardship into resident medical education, which is very interesting. Our final speaker today is Allison Ramsey MD. Dr. Ramsey is board certified in internal medicine, allergy, and immunology. She's also employed at Rochester Regional Health, where she sees adult and pediatric patients. She's a clinical assistant professor at the University of Rochester School of Medicine and Dentistry and is involved in allergy immunology fellowship teaching, along with resident and medical student teaching. She's involved in multiple pharmaceutical-sponsored clinical trials and investigator-initiated grants. She has a special research interest in drug allergy and antimicrobial stewardship. So 3 very experienced clinicians and experts in the field. With that, Dr. Staicu, I'd like to hand it over to you to begin this very interesting webinar.
Yeah, thank you, Marnie, and good afternoon to everybody that's joining us today. This is Mary Staicu, and it is such a privilege to be presenting with Maryrose and Allison on the role of the ID pharmacist, ID physician, and allergist in penicillin allergy and skin testing. As many of you already know, National Penicillin Allergy Day is just around the corner, so we are kicking off our celebration today around raising awareness about the impact of the penicillin allergy label. So by the end of this presentation, you should be able to describe how a collaborative, multidisciplinary approach can augment penicillin allergy reconciliation and skin testing. We also hope to identify and discuss potential barriers to penicillin allergy initiatives and pair them with strategies to hopefully overcome these obstacles. But ultimately, I think we hope to really just build upon your knowledge of penicillin allergy and to inspire you to join us in our efforts to delabel our patients. So there are significant deleterious effects of the penicillin allergy label that really span the healthcare spectra. And given these risks, healthcare systems are now implementing penicillin allergy and skin testing programs really to optimize care in our penicillin allergic patients. I think what's similar to antimicrobial stewardship programs is that there really is no one-size-fits-all penicillin allergy program. It really depends on the resources that you have available at your facility. But because of this has kind of encouraged us to develop creative approaches and interventions, including various and diverse penicillin skin testing models. So currently there are pharmacist-driven models alone or in combination with nurses or allergists or even ID physicians, okay? But many of these successful programs that are described in the literature often include a multidisciplinary collaboration. We're oftentimes working professionally towards the same goal in parallel. So teaming up with other healthcare clinicians makes sense, and it's mutually beneficial for our patients. So Allison, Maryrose, and I spent a long time brainstorming how we should structure this presentation, and we all agreed that the most effective way for us to meet our objectives was to simply share our story as to how our stewardship program came to prioritize our projects focused around penicillin allergy, and then our path to teaming up with our allergists. So to give our story some context, RGH is a 528-bed community teaching hospital. We have medical, dentistry, and pharmacy residencies, and we are one of 5 acute care settings, acute care hospitals in our system. Our stewardship team consists of 2 ID pharmacists, FTEs, and 0.5 ID physician FTEs. And we have inpatient allergy consultation services available. We also use EMR. Epic is our EMR. Okay, so once upon a time, our very first stewardship initiative that focused around penicillin allergy was our AZTreonam Optimization project. So our stewardship team tracks antimicrobial purchases as well as days of therapy, and we noticed that between 2008 and 2011, we saw a spike in our AZTreonam utilization, and we are now spending upwards of $200,000 per year on AZTreonam alone. And this was without any change in our contractual price or rates of our multi-drug resistant organisms or even rates of penicillin allergy. And as a result, it was driving up our Pseudomonas resistance. It was now down to 71% susceptible to AZTreonam, and really this kind of made it an unreliable empiric gram-negative agent, especially for our really sick patients. So we launched the Past is Present campaign in 2013, where we educated our frontline providers on beta-lactam cross-reactivity and our AZTreonam utilization and whether or not or which clinical scenarios it would be appropriate to re-challenge cephalosporin or carbapenem antibiotics. We also created a penicillin allergy screening tool for our pharmacists to use upon order entry. And we incorporated review of AZTreonam orders into our daily prospective audit and feedback process. And I also want to mention that we did not at any point restrict AZTreonam usage. So within 6 months, we saw a 55% reduction in our AZTreonam DOTs, which was equivalent to about $60,000 to $100,000 annually cost avoidance. And this is even after considering costs of the alternative beta-lactams that were prescribed. To date, we've reduced our AZTreonam DOTs by 89%. So not only did this particular intervention save our hospital a substantial amount of money, especially over the last 6 years, but we were able to shift antibiotic prescribing to preferred first-line beta-lactam therapy in our penicillin allergic patients. So this is the penicillin allergy screening tool that our pharmacists used at the time, and it's stratified based on the severity of the penicillin allergy that was reported by our patients. and it directs prescribers to use either penicillin if it's an intolerance or cephalosporin alternatives, or to continue AZTreonam, for which the stewardship team would further review. So while we were reviewing AZTreonam orders, and then subsequently we were reviewing antibiotic allergy histories in the EMR, we realized that there was significant opportunity to improve our allergy reconciliation and documentation efforts. But to really formally evaluate the quality of how we are doing this, we created a standardized penicillin allergy history algorithm, and we interviewed 100 penicillin allergic inpatients and then compared their interview responses to what was actually documented in our EMR. We found that 68% of penicillin allergy histories were inconsistent with EMR documentation upon patient interview. Like, just think about that. There were other themes noted as well. 1 in 3 patients described a reaction, but the EMR reaction field was incomplete. 1 in 5 patients described a reaction that was different from EMR documentation. I mean, this is just crazy. So I think all of us involved in this project were really kind of shocked by these results, but the findings are actually consistent with other published literature. This is something that's been described across the nation. So here's the penicillin allergy history algorithm that we used for this particular project. It starts at the top by asking the patient when the allergy occurred, and then subsequent questions really try to address various types of hypersensitivity reactions. So if the patient answers no to the question, you continue moving down. If the patient answers yes, you move to the right to a suggested management strategy. And the management strategy for this particular project was not rolled out, but we created this with the intent that we would eventually use this for other future projects. Okay. The beauty of this algorithm is that it's simple. It can be administered by students or nurses or even trained allergy personnel, and it only takes about 30 to 60 seconds to complete. Okay. So the results of this project really caught our attention, and it helped us to realize that the gaps in our clinical education were probably larger than what we initially anticipated. So to measure where we should focus our educational efforts, we created a very simple clinician survey that we sent to 2 of our community hospitals within our healthcare system. And the goal was to evaluate baseline clinician knowledge of penicillin allergy as well as self-reported practice patterns. We had about 276 respondents, including medical and surgical residents and attendings, advanced practice providers, and pharmacists. And from the pharmacist perspective, I think that there were some expected findings from the survey, like how conservative most clinicians are when managing our penicillin allergic patients. They oftentimes prescribe or prefer non-beta-lactam antibiotics regardless of what the reaction history was. But one interesting finding that makes this study unique is that pharmacists scored better in both questions that assessed antibiotic cross-reactivity and the clinical vignettes that assess management approaches. So we already know the value that clinical pharmacists can bring to patient care, and I think that this is further evidence that pharmacists should be involved in antibiotic decision-making in our penicillin allergic patients. So I'm going to pause here in the story, and we'll pick back up in a little bit. I think as a group, we've learned a tremendous amount since we initially launched the AZTreonam project. And the very first point I'd like to make is that a thorough penicillin allergy history is the most important step in whatever penicillin allergy initiative that you're rolling out, and that really cannot be overstated. It determines your clinical management approach, and it ultimately helps guide you to which antibiotic is the safest and the most effective to use in that clinical scenario. Penicillin allergy reconciliation, I would consider a universal opportunity for all facilities. You don't need a lot of resources to do it right, and it's extremely useful. You can also develop tools such as standardizing your history algorithm process, or even beta-lactam usage guidelines can augment your initiatives. But I think you're going to have the biggest impact if experts in each field can work together. And I've had this stuck in my head for a while, but allergy and ID live together in perfect harmony. It really is a symbiotic relationship, and working together can improve and augment the quality and the impact of your work. Okay, so I would argue that the pharmacist has the potential to serve various roles during the pre- and post-prescription period, as well as upon order entry. This includes developing tools that clinicians can use to help select the most appropriate antibiotics upfront, or maybe this includes tools that can help obtain accurate, standardized medication allergy histories. It's also very helpful for pharmacists to review prior antibiotic administration data and tolerability. We have these data at our fingertips, and I've been told over and over again by busy clinicians that it's tremendously helpful. So if you can do that, dig up those data and don't forget to document it in the EMR. Since pharmacists are also reviewing microdata and allergy data and prior antibiotic exposure, we are also some of the first to identify patients that may benefit from skin testing. And if you're lucky enough to practice in a state that authorizes pharmacists to skin test, you can even apply the skin test yourself. And some may even argue that penicillin skin testing is a pre-prescription intervention, and I would wholeheartedly support that as well. And then lastly, patient and clinician education is invaluable, and it can help improve your ongoing initiatives. So with some foundational work in our penicillin allergic patients at our hospital, our stewardship team was motivated to continue prioritizing these initiatives. So with that, I would like to introduce our stewardship director, Dr. Maryrose Laguio-Vila.
Hi, thanks, Mary. I'm Maryrose Laguio-Vila, and as you said, I'm the ID physician and antibiotic stewardship director at Rochester General. And I'm going to talk about what we think the role of the ID physician is in these penicillin allergy patients. So my perspective is that since the data suggests that ID is consulted more often than allergy, we are in a key position to promote the importance of penicillin skin testing and to clarify provider and patient misconceptions about the timing, setting, and safety of allergy testing. I'm going to start with a clinical scenario. It may be a scenario you've seen before. The case is one of severe orbital cellulitis. The notes in the medical records state that symptoms are improving with IV antibiotics over the last 2 days. There is MSSA growing, and the plan is to continue IV Vanco and Clinda, and that considering her penicillin allergy, the primary team notes that an ID consult will be requested for antibiotic selection. And I put this meme in here because I think it illustrates what happens rather frequently in this kind of scenario. An ID consult is more often pursued with the intention of finding a non-beta-lactam antibiotic rather than consulting allergy to help assist in evaluating the true nature of the allergy. The low frequency of contacting allergists has been found in several studies. Mary talked earlier about their healthcare provider survey, and despite that the majority of respondents had been in practice over 10 years, still 55% stated they have never consulted an allergist, with an additional 32% stating they consult an allergist only 1 time per year. Similar in frequency of taking advantage of allergy consults are described in surveys in Canada and the UK. In the UK survey of 164 providers, not only did 64% never refer to allergy, 56% admitted they were not even aware of the availability of allergy testing. This suggests that on the one hand, part of the issue is a lack of awareness of the existence of skin testing, but on the other hand, of the providers that are aware, calling an ID consult may be more routine than calling the allergist. So because the ID consultant is more likely to be contacted, I think one of our roles in ID is to minimize the misconceptions about the penicillin allergy, raise awareness about the advantages of allergy assessment, and amplify the recognition of the benefits of the beta-lactam antibiotics. We probably shouldn't expect our patients to know what is a first-line antibiotic and how it is different or better from another. To them, quite often, one antibiotic is the same as the next. But we in ID have the training and the knowledge to explain to our patients when, why, and how beta-lactams are first-line compared to these other agents. and the benefits of beta-lactam antibiotics are numerous. First, they are still the drug of choice for a lot of infections. On the left is a list of just a sample of the pathogens for which a beta-lactam, specifically the penicillins and cephalosporins, remain the first-line agents. Some are very common, like the staph and streps and enterococci, while others are more rare. But there is a tremendous opportunity to use beta-lactams in everyday infections. And on the right, I have the number of guidelines from the IDSA website. Of 63 guidelines, 29 have specific recommendations regarding antibiotics to treat or prevent bacterial infections. Of these, 23, or 79% of them, recommend a beta-lactam antibiotic as first-line therapy. That's a lot. And this is often because we know that study after study has shown that for many infections compared to non-beta-lactams, a beta-lactam is associated with better clinical outcomes, better microbiologic clearance, lower rates of relapse, and lower rates of death. So when we have a patient with a reported penicillin allergy, we as treating providers have an obligation to explain to them whether the risk of challenging the penicillin allergy is greater than or less than the risk of deviating from the guideline-recommended standard of care and risking potential treatment failure. Is it worth taking a second-line agent when a penicillin allergy assessment can be done? In their survey, Mary and Allison created a clinical vignette of this exact scenario. It was of a patient with a history of a penicillin allergy and a serious ampicillin-sensitive enterococcal infection. Ampicillin, as those of you know in the ID realm, is the drug of choice. Yet 59% of non-ID respondents in the survey stated they did not consider penicillin skin testing, given the scenario. And I'm just going to comment here, coming from the stewardship part of me, about the positive impact that I think clarifying and challenging the reported penicillin allergy will have on the antibiotic pipeline. First, we need to optimize the use of antibiotics we still currently have. So as a steward, we are all about the right antibiotic, right? Given a patient reporting a penicillin allergy, we need to clarify the allergy so we can use the right of already available first-line antibiotics. Second, stewardship is an extension of the patient safety environment. Of the currently available second-line and salvage antibiotics, we shouldn't be using them for those same common infections when a penicillin or a cephalosporin is an option. These salvage antibiotics are often broader spectrum than needed, more toxic, and their use is often associated with further drug-resistant bacteria. So we should really save them for when they're really needed and not use them in a patient with an unconfirmed penicillin allergy. Last, many of the newer agents are beta-lactam derivatives anyway. So to challenge the penicillin allergy and confirm or negate its presence may be advantageous for the patient now and in the future. So I hope what I've said already isn't terribly new information, but hopefully it's at least connecting some dots already in your mind for those of you who are the ID consultant or thinking of calling one. But what I'd like to discuss next are a few of the penicillin allergy myths we've come across that may be barriers to consideration of challenging the allergy. The first one is that the belief that the penicillin allergy is lifelong. In their survey of providers, Mary and Allison found that when asked whether the penicillin allergy resolves over time, 42% of respondents did not think that the allergy did. They also did a second survey, which will actually be presented in the upcoming ID week, that involved admitted patients with a documented penicillin allergy. Of these patients surveyed, even more felt like the penicillin allergy did not resolve over time. But the fact of the matter is that it does. Half of patients will outgrow their allergy within 5 years, and 80% will outgrow it in 10. And individuals with a remote history are very low risk for having an allergic reaction upon rechallenge. Knowledge of this fate of the penicillin allergy is important as it becomes the crux of whether or not you might consider skin testing or doing a challenge. Without this fundamental knowledge, you also may not know to ask in the allergy history when did the reaction occur or how long ago. The second myth is that the penicillin allergy label is harmless. In that same survey of patients, they found that many were unaware that the penicillin allergy was associated with a higher risk of infections with resistant bacteria, and more were unaware that penicillin was less costly financially compared to other antibiotics. But in fact, the penicillin allergy label has many implications across the healthcare spectrum. First, it leads to more exposure to different types of antibiotics. Second-line coverage often requires multiple antibiotic agents and polypharmacy. Instead of giving piperacillin tazobactam, a patient may get vancomycin, AZTreonam, and metronidazole. This often means broader spectrum antibiotic exposure, which in turn leads to more selective pressure and emergence of antibiotic resistance. There are more adverse drug reactions that potentially occur, and all of these factors contribute to increased cost and longer lengths of stay and higher readmission rates. Myth number 3 is sort of a catch-all statement. Some condition that is felt to preclude skin testing. My patient is blank, so skin testing can't be done today. We have heard this often, particularly in patients whose clinical situation seems fragile. And it reminds me at least of this statement from the El Khalifa survey of UK providers. He put out this statement asking for level of agreement. Regardless of the details of the allergy history, it is always better to play it safe and not use beta-lactams in patients with a penicillin allergy label. 60% of respondents agreed with that statement. But there is growing evidence to show that skin testing is safe in a variety of clinical scenarios. My first example is in the pregnant population. Beta-lactams are some of the safest antibiotics to be used in pregnancy and are first line for many of their infections. But carrying the penicillin allergy label has the same detriments previously noted, as well as being associated with a higher incidence of postoperative wound infections. But know that penicillin skin testing has been prospectively studied here. First, Macy recruited pregnant patients with a reported penicillin allergy and did skin testing. Of 56 patients recruited, 53 were skin test negative and were able to receive penicillin safely. In a second study, Philipson and colleagues prospectively referred pregnant women who are positive for group B strep colonization and had a reported penicillin allergy. They referred them to their allergy colleagues for skin testing. Of the 28 pregnant patients enrolled and skin tested, 29 or 89% had a negative skin test and were able to receive intrapartum penicillin for group B strep prophylaxis. None of these had an adverse reaction. Another population where providers might feel iffy about penicillin skin testing is the immunocompromised, particularly those neutropenic or receiving cancer chemotherapy. This is important as Huang's study out last year in Clinical Infectious Diseases described an even higher prevalence of penicillin allergy labels compared to the general population. They also found that carrying that label was associated with the same untoward effects. Just out a few weeks ago, Tarimi reported results of their quality improvement initiative at MD Anderson, where they introduced penicillin skin testing with a team consisting of an ID physician, ID fellows, ID pharmacists, and ID advanced practice providers. The ID pharmacist screened oncology patients, and they enrolled 99 for skin testing, for whom the ID attending, APPs, or the fellow did the skin tests. And for those who were skin test negative, they followed with an oral challenge. 95 out of those 99 had a negative skin test result and tolerated the oral challenge. In the 11-month follow-up period, 65 of those 95 negative skin test patients were later admitted and received a beta-lactam for therapy with none experiencing allergic drug reactions. So skin testing in this population is doable and safe, and it also gets them on first-line antibiotics. The last fill-in-the-blank response we observe is just that the patient is either too stable and ready for discharge. So it is suggested that the patient just get penicillin skin testing as an outpatient. Well, in the patient surveys Mary and Allison conducted, they asked the patients where would they feel the most comfortable getting skin testing. More than half of them said they would be more likely to have it done if it was done while in the hospital. And I think this may be due to a sense of safety if it is done as an inpatient. For the patient who with a prior severe anaphylactic reaction, the hospital may seem like the ideal place to be if one were to recur. So, because ID is often the first call for consult, an ID physician's role may be to clarify misconceptions about infection management and allergy assessments. First, address the under-recognized benefits of beta-lactams in therapy and minimize the overestimation of second-line antibiotic efficacy and safety, as well as raise awareness of the risks associated with the penicillin allergy label and the safety of the penicillin skin test. We found that there is an overall limited understanding of penicillin allergy and a wide variation in the clinical management of this patient population. So when I'm on ID consult and I have a penicillin allergic patient, I ask the primary team to contact allergy. And when I'm not on ID consult but wearing my stewardship hat, our program still recommends allergy consult. On the right is an example of our stewardship note that goes into the medical record. We summarize the case and the reported allergy and include these educational points. To facilitate consult and make it as easy as possible, we also include the direct telephone line to contact our allergy colleagues. And with that, I'd like to hand it over to one of them, Dr. Allison Ramsey.
Hello, everybody. This is Allison Ramsey. I am an allergy immunology physician, and I work with Mary and Maryrose. And I recognize that not every hospital has the resource of an allergy immunology consult. We are lucky here to be able to collaborate together with ID and Allergy. And I wanted to start by saying how I think an allergist can add to a penicillin delabeling program and an antimicrobial stewardship program. So we as allergists have the expertise to take a detailed and accurate drug allergy history. And that's because we're thinking along immunologic lines. So we are able to tease out what is an intolerance, what sounds like an immediate allergy based on symptoms, what are the red flags that show that a medication should continue to be avoided. Along those same lines, we have experience with recognition and management of anaphylaxis. So as most of you know, I as an allergist and most allergists spend most of their time in the outpatient clinic treating other conditions aside from drug allergy, so allergic rhinitis or food allergy. And in the context of caring for those patients, we see a fair amount of anaphylaxis, and that presents very similarly whether it's food or medications or allergy shots. So we have experience recognizing anaphylaxis and managing it, and we recognize that treating it early is appropriate. And then in the immunologic realm of what can go wrong when someone is being treated with penicillin or another antibiotic or another medication, certainly anaphylaxis is what we worry about with an IgE-mediated reaction, but then there's other immunologic pathways and immunologic reactions that can happen. And some of those reactions can be even more life-threatening than anaphylaxis, and those are the more severe cutaneous reactions. So I think we as allergists are trained to recognize the red flags in symptom histories with more severe cutaneous reactions like Stevens-Johnson syndrome or toxic epidermal necrolysis or drug rash with eosinophilia and systemic symptoms. So our drug allergy history not only screens for, hey, does this allergy sound like an immediate type allergy? What's the time course of it? And do we see any red flags for these other severe reactions that can occur? And even if your own institutions or places of practice don't have an immediate allergy consultation available, the literature is sprinkled heavily with allergy-created tools to screen people for penicillin allergy specifically. There's a very robust body of literature growing up around how different institutions have, dealt with their own individual resources and how you can overcome not having an allergist if you don't happen to have anybody on staff. Many of these tools are developed with allergy input. So everybody has something that they're best at, right? So I'm an allergist and we do skin testing. And in case anybody hadn't seen what penicillin skin testing looks like, it's not that different than anybody undergoing food testing or environmental allergy testing. The first step is what we call skin prick testing. And I put a picture up there. We use a positive control, which is histamine, a negative control, which is saline, and then we use penicillin G, and then we use pre-pen, which is the major determinant of penicillin. And so we just do a little prick in the skin. It just disrupts the epidermis. And if someone is allergic, they'll get an itchy bump that looks like a hive. The spoiler alert is that in most penicillin allergic patients, this is negative. And so I'm sure you all know that most people reporting a penicillin allergy have negative skin testing. I don't think in my career I've ever seen a positive skin prick, or maybe one. So then the next step of skin testing is intradermal testing. And that's where we take the same reagents. Instead of just pricking the epidermis, we inject it intradermally. And if this bleb that you see on the screen, if that grows, then that to more than 5 millimeters, then that is a positive test. So this is what we're talking about, the nitty-gritty of what we do when we do penicillin skin testing. And I don't pretend to, I don't pretend that only an allergist can complete skin testing, but I do think that the advantage that an allergist has, or allergist developed tools have, is that we are able to correctly identify who's appropriate for skin testing versus who's not. So then this is how you interpret a penicillin skin test result. It is a much better test for ruling penicillin allergy out. So it is a sensitive test. So a positive penicillin skin test only shows about a 50-50 chance of reaction. Those odds are not something that we're comfortable with in medicine in general, so we say continue to avoid penicillin. If the penicillin skin test is negative, then the way that I deliver that information to the patient is I say your risk of having an immediate reaction to penicillin, most people recognize the term anaphylaxis, so I say an anaphylactic or immediate reaction to penicillin is that of the baseline population. So it is of acceptable risk for you to try penicillin again. And what we've ruled out here is just an immediate reaction only. We can't predict side effects, we can't predict more delayed reactions, but anaphylaxis is usually the reason people are scared to try penicillin again. So now we're picking back up with our story time that Mary so nicely started for your after lunch nap. I'm just kidding. So after providing my input on the tools that Mary and colleagues had developed on the inpatient side, we realized that there was a generous population in the hospital that we could help get to better antibiotic treatment. And every hospital, every system is dealing with limited resources. We don't have allergists sitting around waiting for business on the inpatient side of the hospital. So you have to triage what patients you want to target. And it may be the groups that Maryrose mentioned, groups that get a lot of medical exposure and a lot of antibiotic exposure. In this project, we actually targeted patients who were on high-risk second-line antibiotics. And we took patients who reported a penicillin allergy, who were hospitalized for an infection, and were on non-preferable antibiotics, including vancomycin, linezolid, daptomycin, moxifloxacin, and AZTreonam. So anybody who was on those medications had a penicillin allergy and had an infection better treated by a penicillin-based antibiotic or a beta-lactam underwent skin testing. And we skin tested anyone who had an appropriate history through the screening algorithm that Mary showed earlier. So people with a history suggestive of an IgE-mediated reaction or a history of rash. And we did this in 50 patients, although we screened many more. In the 50 patients who underwent skin testing, 47 of 50 of them had negative skin testing. And you can see the demographics of that patient population on the right. So I'd like to show you first on the right side of the screen with the pie charts. You can see in our cohort, vancomycin was by far the antibiotic that the majority of people were being treated with. AZTreonam came in second at 22%, and this was even in the face of our past is present algorithm institution. So some patients were still ending up on AZTreonam, and then followed by moxi, dapto, and linezolid. Post-testing is the pie chart in B, and you can see that patients ended up on beta-lactam antibiotics. And I will say that our culture during the time this study was ongoing was shifting, but as we undertook this study initially, it was really the culture to avoid even cephalosporins in a lot of penicillin allergic patients. So we considered it a victory that patients were transitioned to first and second generation cephalosporins, third and fourth generation cephalosporins, and penicillin-based antibiotics. And on the left, you can see how many days of second-line antibiotics that we avoided based on the clinical indication. Vancomycin alone, we had 863 days of second-line vanco saved. We had a very conservative calculation for our cost savings at $70 per patient. It was undoubtedly significantly higher if we took in secondary costs like monitoring of vancomycin levels, or potentially the issue of someone being readmitted if vancomycin caused acute kidney injury. So just with direct antibiotic cost savings, we save $70 per patient. And again, not looking at future savings or indirect savings. So with this project and the projects that Mary discussed, and for the reasons that Maryrose discussed, we, as just this little fearsome triumvirate, really raised awareness among our colleagues in this pretty big hospital. So not surprisingly, our hospital medicine colleagues took notice because the majority of patients in our initiatives were on the hospital medicine service. But certainly we've had buy-in from critical care and surgery, urology in particular because they deal with a lot of recurrent urinary tract infections. Hematology oncology has emerging literature and certainly has been taking notice of our work here as well. And then OBGYN for pregnant women with group B strep colonization, I would argue that's an untapped and understudied population that stands to benefit from delabeling services, and there's a growing body of literature there, as Maryrose mentioned. So yes, as the literature grows and the data grows for delabeling these patients on these services, that was happening here at home in our hospital before our very eyes. And as is happening on the inpatient side, on the outpatient side, we as allergists also promoted this as a service that we can provide to all of these different specialties. I'd like to point out dentistry in particular has been a huge referral source for us as allergists because they love using penicillin-based antibiotics for oral infections. And there's a study of dentists that show they are actually the third most frequent prescribers of antibiotics behind internal medicine and family medicine. And just as an aside, we've also found in terms of uptake of recommendations or being proactive about referrals, APPs, so PAs and nurse practitioners from all specialties seem to really be able to kind of change their practice patterns right away. And so we've seen a lot of referrals from them, from all specialties. So here's what happens when you raise awareness among your colleagues. And this is on the inpatient side at Rochester General Hospital. You can see we as allergists averaged just around 30 consults per year, 2014 and 2015. Back in 2013 was when the AZTreonam initiative started. Then we did our sort of review of how our drug allergy histories looked in the EMR. And then the 2015 to 2016, you don't see a spike in consults because those patients were all a part of our second-line agent study that I just showed you. But you can see when we ended that study in 2016, we were missed, and so consults went up significantly. So this was not part of a formal study, but we had spread the word, the good word about delabeling penicillin allergy, and saw the fruits of that in our increased consults. So then the question becomes, how do we allocate resources? So we can't skin test every patient who comes in with a penicillin allergy with an infection. It is fairly work intensive to keep targeting patients on the second line antibiotics we initially targeted, although we've stuck with that for the most part in practice through notes like Maryrose showed in her portion of the presentation. But then we're also now thinking more about how do we use our resources more smartly. So we want to work smarter. And one way that we thought about doing that is with telemedicine. So you can't see me speaking right now, but that actually is how I look when I speak on a computer. I'm at the lower right-hand corner. And in this particular case, I'm clearly providing excellent medical advice to Alexander Fleming, who discovered penicillin. And this is an example of a telemedicine encounter. So after we finished our targeted second-line antibiotic study, we looked at if we could use telemedicine to delabel penicillin allergy. And in this study, we actually had a PA come to the hospital who was trained in skin testing. She would take the penicillin allergy history using the algorithm that we previously showed, and then the patient would ask her questions, and then they also knew that at the end of the encounter, they would get to FaceTime with an allergist to answer any questions, to go over their skin testing visually and discuss what it meant. And what we found in this study was that patients actually really didn't care if they saw me in person or if they saw me on FaceTime. Patients had a good overall rating of their impression of telemedicine. They were overall satisfied with their telemedicine encounter, and most of them were pretty neutral or didn't agree that they needed to see an allergist in person versus on FaceTime. And I will say for this particular pilot study, we cautiously went with a physician assistant to do the skin testing, but I would be very comfortable in the hospital setting having a trained LPN or RN doing the skin testing portion. So then, still, telemedicine, we're still having an allergist sort of sub in at some point during clinic hours. We have some boots on the ground here with a PA in our case, but potentially could have been an RN or LPN. We've begun to think more about how else can we allocate resources appropriately. And that's when we started looking into incorporating direct challenges. So I'm an allergist, I love skin testing, but a secret is that we probably don't need to skin test everybody for their penicillin allergy. And so we modified our penicillin allergy history algorithm to incorporate direct challenges to penicillin in patients with low-risk reaction histories. And I'll call your attention to kind of the middle of the screen. We gave options here to do graded challenges to cephalosporins in patients who were penicillin allergic because we know the cross-reactivity there is exceedingly low and probably not anything to worry about. In patients who had a nonspecific rash or symptoms suggestive of an IgE-mediated reaction, in patients with a history of an IgE-mediated reaction at any point in time, still underwent penicillin skin testing. So if they had swelling, respiratory symptoms, cardiovascular changes, etc., they still underwent penicillin skin testing. In patients with cutaneous-only symptoms, if their cutaneous-only symptoms were more than 20 years ago, or if they had an unknown reaction more than 20 years ago, we recommended a graded challenge to penicillin. And this is on the inpatient side on a regular floor without any additional monitoring. What we did for the graded challenges is we gave 1/100th of the dose of amoxicillin, waited 30 minutes, gave 1/10 of the dose of amoxicillin, waited 30 minutes, and then gave the full dose. For the inpatient side of this data, we're still tallying that up. Those results will be shared shortly in the world of penicillin allergy, but I can say that we did not have any significant reactions to our graded challenges. We did a similar initiative on the outpatient side where we actually randomized patients with cutaneous-only reactions to be skin tested versus or just undergo a graded challenge. And we found that the majority of people passed their graded challenge, which is the DC side here. Only 3%, almost 4% failed it, which was only 3 patients out of 79. All of their symptoms were minimal, none required epinephrine. We found that about 10 of 80 patients actually had a positive skin test, so we hypothesized that skin testing is probably overcalling penicillin allergy. In addition, we showed that direct challenge in the outpatient setting is a little bit shorter, and it also costs less. So similar data for the inpatient side, we didn't randomize, but we will shortly be presenting that direct challenges are safe on the inpatient side as well. So then our last way of smartly allocating the resources that we have is we are now looking into EConsoles, because not every patient needs an in-person interview regarding their penicillin allergy history. So we are going to pilot a program where we review patients' allergy history, and in these cases, I suspect we'll be able to find the low-hanging fruit where patients have symptoms consistent with an intolerance, and we can tell the physician on the phone, just delabel them, because sometimes taking the allergy out of the black box of the allergy field is difficult for people to actually do. We'll also be able to find the patients who should just avoid penicillin indefinitely because they have red flag symptoms like blistering or oral mucosal involvement or Stevens-Johnson syndrome or something to that effect. Otherwise, we will also be able to identify patients who are low risk, and maybe we can say, hey, this is someone who's low risk. They could just have a challenge on the floor. If you have questions, you know where to find me. So we're hoping that this will be able to spread out expertise of our professionals a little bit more smartly without skin testing all patients or interviewing all patients if it's not needed. So this is soon to be piloted, and there is some data on this already in the allergy community. So our conclusions for our talk, and we thank you for your attention, is that we hope we've shown that a multidisciplinary team has been the key to our success. As you can see, based on our story, we've benefited from input from our pharmacy friends, infectious disease friends, and allergy immunology friends. We all know that there's individual, institutional, and public health benefits to be gained from penicillin allergy evaluations. And there's many strategies that can be employed, some of which we have presented and some of which we have not. But it's almost like an a la carte of how you want to improve penicillin allergy stewardship in your institutions. And with that, we are happy to take any questions.
Thank you so much to our speakers, Maryrose, and Allison. That was just terrific. Just as we're waiting for some of the questions to come in and also to review some of them, I thought I would just start with a few questions related to your multidisciplinary team. How, maybe Maryrose, as director of the stewardship program, did you engage, and then Mary as a part of that, did you engage with Allison? Is that something that, to form this interdisciplinary team to bring on for this allergy testing initiative? I was just wondering how your team formed, how you got connected.
Well, good question. It's been going so long, we're trying to reminisce. Well, you know, I think an advantage of our hospital is that although our bed size is 500, it's still kind of a community feel. So we've known each other professionally, and then we just seem to have mutually beneficial priorities. So what started over water coolers and lunches and quick emails of, hey, what do you think about this, sort of evolved into a, well, we actually should probably address this because all of these little things are just scratching the surface of something that's much bigger. Now, would you guys say something else, or?
No, I agree. So I remember maybe, I don't know, 5 or 6 years ago leaning on my colleagues regarding antibiotic desensitizations, where someone had run out of any option, and that would be the only time someone would call allergy is they have nothing else to offer their patients and they needed desensitization. So I would, maybe Maryrose suggested that, and then Mary Staicu is the person in the pharmacy who I have to coordinate the desensitization with. And then you work together on a few of those cases and you realize there's probably a better way to address this.
Yeah, I think I just wanted to take a step back and talk about that. Just as antimicrobial stewardship teams are formed and you have pharmacy involved and physician and ID physician and nursing, but actually incorporating this as part of the stewardship initiatives and then including allergy and immunology is an important role. You've really strongly highlighted that. A question that's come in is, maybe Allison, you may want to take this one, but would you ever utilize the penicillin skin testing if a patient only had cephalosporin allergy listed in the EMR?
Oh, that's a good question. So I am probably pretty lax about that. So if I can talk to the patient and hear that they've tolerated penicillins, I won't worry about a cephalosporin allergy. The only time that might get my attention is if the reaction was relatively recent and severe. which doesn't come up that frequently. So most of the time, if people have a cephalosporin allergy, I'll say go ahead and give penicillin, and my only asterisk there would be if they had a recent, like within the past 1 to 2 years, severe anaphylactic reaction to a cephalosporin, I might just, for my own reassurance and the patient's reassurance, skin test them to penicillin prior. But the data on the cross-reactivity between the two is really poor. I mean, and there's not much supporting data for, you know, what we were all historically taught about cross-reactivity. So going the other way around from penicillins to cephalosporins, I barely worry about that too.
Correct. Okay, great, thank you. Someone's just asked the question about the slides available for download, and I think this is a good time to just tell everyone that I believe the 3 of you will be presenting at ID Week, and we'll be there, and so people can actually meet you in person if they have more questions, but also the slides and the handout for this presentation and the recorded webinar will be available immediately following ID Week, October 6th. So just letting everybody know that. It seems the algorithm is really important here. How is that available in your hospital? And then I'm curious if it's available at all online such that people could get access to it versus having to recreate their own.
Yeah, hey, this is Mary, and the algorithm is actually has been published in a couple of articles in JACI IP. So on the slides that we reference the algorithm, you can see the reference at the very bottom, and you can pull the algorithm out for your own records. But here at RGH, we have the algorithm electronically available on our stewardship website. And we are in the process of having this algorithm actually incorporated into our EMR. So for any penicillin allergy that is recorded in the EMR, it's going to prompt the nurse to ask these questions. I think which will be really helpful to standardize right from the beginning and to have an accurate and complete allergy history as the patient presents to the ED.
Yes, just getting that granularity around the allergy, which historically has been difficult. Do you ever have a penicillin allergy or not? And there's not a lot of detail. So I think that is a great tool. So people will be able to get access to that through one of the articles that you mentioned. We have another question. I don't know if our speakers can see their chat box there that came in. Regarding, do you use R1, R2 chain charts to assess specific cross-reactivity to specific cephalosporins and penicillins versus grouping cephalosporins and penicillins together?
So this is Allison, the allergist.
Yeah. Can you answer that?
Yes, absolutely. So certainly it depends on the clinical scenario. So if someone has a penicillin allergy and their team would like to use a cephalosporin, I generally recommend a graded challenge to the cephalosporin. Unless it's like the same side chain as ampicillin, then I might skin test. With specific cephalosporin allergy, which is much less common than penicillin allergy, then I absolutely look at the side chains and recommend challenging to a cephalosporin with a dissimilar side chain. If someone needs like the same cephalosporin that they have a pretty convincing allergy history to, or if they need a cephalosporin in the same R group side chain, then I would recommend a temporary induction of drug tolerance or a desensitization.
Okay, thank you. Another question that I thought was interesting as listening to the presentation, it's about slide 32, but it looked at in your 50 patients that you assessed that had a penicillin allergy, so they were on vancomycin, linezolid, daptomycin. So they went through the testing, and then you looked at your results of how the antimicrobial changes happened, and the overall it's the table off to the left-hand side, that the days of second-line antibiotics avoided, the total being 962. That's, you know, that's really remarkable off of the approximately 50, I think it was 47 or something patients that you were able to make changes to. I think it's a very interesting research endpoint that you tracked there that could have a big impact, because with stewardship, obviously you're trying to narrow spectrum to avoid further promotion of antibiotic resistance. So that really struck me, that reduction.
I think it's important from a stewardship standpoint and even an individual health standpoint. I mean, some of these people were people facing like, you know, a PICC line with vancomycin, who ended up being able to go home on some oral option. And I agree. I think it's incredible that this was just in 50 patients.
Yeah. This is Mary. We actually had a large proportion of patients that had MSSA endocarditis, which is why our vancomycin days of therapy avoided was so substantial. But we actually have been tracking days of second-line therapy avoided as a stewardship metric for the last couple of years, because, as you mentioned, Marty, it's an important finding, and it can show avoidance of these, you know, more toxic second-line antibiotics. You can really put some more meaning behind these numbers when you show them.
Yeah, I think that's exactly, it's a very good metric, a stewardship metric to follow as we look towards what data do we collect in the research results and findings. We're actually out of time, unfortunately, so I'm going to have to close this out and refer people to ID Week for your presentation. So I'm going to conclude the Antimicrobial Stewardship Project webinar and remind everyone it is recorded and will be available on our CIDRAP-ASP YouTube channel website after October 6th. I want to thank our presenters, Dr. Staicu, Dr. Laguio-Vila, and Dr. Ramsey, for a fabulous presentation today. And I also want to thank Maya Peters from our CIDRAP-ASP team in the planning and production of this webinar as well, and to our listeners for participating. Feel free to send us your ideas for our next webinar topics at cidrap.umn.edu/ASP, and we look forward to hearing from you. Thank you so much, Maryrose, and Allison. Really appreciate it.